There continues to be new and emerging data coming for patients with relapsed and refractory myeloma. What we're seeing at this year's meetings is additional data for the use of the anti-CD38 monoclonal antibody Isatuximab, and also some new and emerging data for the use of immunomodulatory agents such as CC92480, the new CELMoD. Isatuximab is a monoclonal antibody which is similar but slightly different from daratumumab, and we know is now licensed in Europe and US in combination with pomalidomide and dexamethasone. The next phase is combining this with proteasome inhibitors, and there's some nice data looking at the comparison of carfilzomib and dexamethasone versus carfilzomib and dexamethasone alone. And what we do see is an improvement in response rate and progression-free survival for the triplet combination. So again, this adds to the data that we see. We've already seen data from CANDOR, which was daratumumab in combination with carfilzomib and dexamethasone, and now we're similarly seeing data with Isatuximab. So what's nice for clinicians now is that we have a choice of two CD38 monoclonal antibodies. We do need to generate data for the use of sequencing for these monoclonals, but certainly we have a variety of different approaches to use for patients depending on what they can access and how easy it is for them to come up to the infusion center. Now, we're used to seeing immunomodulatory agents in use, and at last year's meeting, we saw data for iberdomide, which is CC220 being presented, which is the new immunomodulatory agent. Now, this year, Paul Richardson is presenting data for CC92480, which is the new CELMoD, and I was fortunate to be able to be part of this clinical trial. Now, this is a very interesting CELMoD, because if you look at this in vitro, it is extremely potent in terms of the levels of cereblon inhibition. And what you see is that cells only need a very tiny amount of cereblon to be sensitive to this agent. So I'm quite excited by this based on the preclinical data. In the phase 1 clinical trial, we investigated a number of different schedules for CC92480 to try and understand what the correct approach might be, because we're expecting to be seeing quite a lot of myelosuppression due to the cereblon inhibition. What turned out was that the best schedule to use is a 21 out of a 28-day schedule, which is actually the same schedule that's being used in IMiDs. And we saw some very good and high response rates in very heavily relapsed and refractory patients. And interestingly, we're seeing responses in pomalidomide refractory patients, which is something that we haven't seen before, and particularly patients who had recently had pomalidomide. In addition, we're seeing responses in patients with extramedullary disease as well. So I think that this is certainly an agent to watch. It appears to be fairly well tolerated. The levels of myelosuppression are acceptable with the use of G-CSF. We didn't see anything untoward in terms of a side effect profile. Being oral, it's fairly easy to give, and in the doublet formation lends itself to be a very nice regimen to be used with other agents. And so I look forward to further reporting of studies which are combined with other standard of care agents coming through in the future.